Okay, I'm so thankful to have you today here, Dr. Espino, to talk about pessaries because I know prolapse is a term that is on several people's minds, and I think sometimes it creates a lot of fear, and it sounds scary, and a lot of clients don't know their options. So I appreciate you taking the time to talk about this topic with me today. You're someone that I've heard great things about from your clients. People really respect you, and they are always very appreciative of the time that you take to talk to them. Those are some of the things that I hear about you in the community. And I've also appreciated your collaboration with other professionals, because I think that this really helps our clients when we can kind of come at this from different angles. Will you tell everybody that's listening, though, a little bit about who Dr. Espino is?
So I'm from Winnipeg. So my primary training was all done in Winnipeg as a medical student. And obviously everyone who lives in a prairie setting wants to be outside the prairie setting just because of the weather. But I migrated obviously in BC for the rest of my training and residency. And I've been practicing now in Kelowna since 2020. So I got recruited during the pandemic. I did, prior to that, 2 years of locuming and taking over people's practices over in the Lower Mainland, mainly in like Vancouver hospitals. So I'm a general OBGYN. I joined the group here in Kelowna as one of the 9. So we're a big group, pretty big practice of obstetrics and gynecology now in Kelowna, I think with a 13% growth here of our population. So, but we do a lot of bread and butter as one of the 9 here.
Awesome. And can you, because we're going to kind of hone in on a very specific topic in pessaries today. Mm-hmm. Can we start with a bit of a bigger picture in that, because all of our care is guided by evidence. And so I know as physios, we have different guidelines that kind of help us tailor or focus our practice on someone's symptoms. And I wonder if you can talk a little bit about what the guidelines are that you practice under that kind of help to direct your care when it comes to prolapse. So I guess I'm wondering, when someone comes in with symptoms of prolapse, what kind of algorithm or what kind of thoughts are you going through as far as your treatment goes?
Yeah. So when they get referred to a gynecologist, like myself, for the most part, from a family practice point of view, they get assessed and then, it looks like prolapse. And then, they wait 9 months or a year to come see gynecologists. And for the most part, either they're differentiated or non-differentiated, right? Meaning that some people have done their best to optimize their symptoms and make it better. Lifestyle changes, conservative measures. And so what my first goal is how bad is this prolapse and does it coincide with what their symptoms are? And it's challenging because prolapse is not necessarily just prolapse, right? So 3 things can come down from a pelvic point of view. And sometimes they're associated with other symptoms like incontinence or bowel movement issues. And so my job as a gynecologist is to be able to kind of, it's hard with the virtual care that we have now. A lot of people are either ignoring their symptoms or, it's not too bad, or, and they don't get examined or assessed. And so it's also challenging because prolapse is not necessarily a 1-to-1 ratio in a sense that, my symptoms are equivalent to what I see physically. Some people have lots of symptoms and very minimal prolapse, and some people have like very minimal symptoms and then really dramatic prolapse. And so my job as a gynecologist is to see firsthand, examine how bad is it and does it coincide with what they're saying are their symptoms, and then what we can do about it in terms of treatment. And so guidelines wise, obviously, when I was in training, a lot of it is dictated by our Society of Obstetrics and Gynecology in terms of how we treat and recommend programs for prolapse management. And one of the first 3 guidelines are basically conservative ways to manage it, right? So number 1 is pelvic physio. The second is like pessary care and incontinence. And then the third is like, probably multi-tiered surgical management. And all of them are an amalgamation of guidelines in terms of, evidence-based or what people have done to manage it when they do big studies to see this is effective, this is very much so, have 80 or 90% success rate in terms of treatment. And then you kind of go to the specific subspecialty, which is urogynecology for treatment of prolapse. And there's lots of different kind of avenues that you can take from there. But, as a generalist, especially in a community where you have a lot of retired, population that are very active, especially in Kelowna, you'll see, I think, a big proportion of our patient population is a prolapse. And so it's very important that we optimize conservative management, that guidelines are kind of, they're set forth there, but they're not necessarily updated, right? So every 10 years, a group of gynecologists or subspecialties will sit down and review everything. And it might take a while to be able to say, oh, there's new studies that show this is very effective. And so some of them are updated, some are not. But I think all the hierarchy in terms of treatment follow the same guidelines, that optimize conservative ways to manage this first.
And I love that you kind of mentioned that. I mean, obviously I'm pro physio because that's my job, but I love that. Like, I've actually really noticed since we have lots of new gynecologists in town, and I've noticed how proactive you all are with recommending the conservative treatments first, because I do think that in the past there was a misconception that, like, oh, anything to do with kind of my private parts, it is surgical. And I think if you think, I always mirror other orthopedic injuries, and as physios, we are working with these people very closely before they see a specialist. Like, if someone has like a shoulder problem, they can't, do what they need to do in their sporting world or in their day-to-day activities, you wouldn't wait necessarily for an orthopedic surgeon first. Generally, it would kind of be, let's start with conservative, let's do what I can do with physio. And then as physios, we can see really quickly when this is outside of our wheelhouse. So to then maybe send back to their GP who might need to refer to the orthopedic surgeon to look at that first. But I do find it's a bit backwards in the women's health world, that it's generally GP straight to gynecology and then back to conservative management. And I'm not saying that you don't do conservative management, but I am seeing a lot of those referrals now back to physio. And sometimes these people think, oh my gosh, I waited for a year to get the advice to see the physio that I could have had right away. So I think kind of paralleling other things or other areas of our body, it makes sense, doesn't it? It's just not how we're practicing right now.
I think part of it too is just a lot of education, right? With pelvic floor, we don't see it, we don't treat it, forget about it. I think that's for the most part. And, the population of women that are severely affected by it right now are the ones that never talked about it. So right now with the new, our new generation of women, everyone is forthcoming about, the physical issues and how to manage it, and everyone with the internet, accesses all the information that they can. Whereas in the past, I don't think it's speaking from experience, my mother or your family members, like, oh, I didn't know that was an issue, until it's really bad, until your quality of life is severely affected, especially for very, very active people. And, we forget that, pelvic floor is a group of muscles and ligaments and, a whole host of different physiological aspects of us that support all our entire being. So if you don't focus on it, kind of like, your triceps and muscles that support your upper body, strengthening is the number one approach to this, right? So a lot has to do with education. And, as physicians, we are only limited as to how much we can educate. And I think part of it too is that, as a group, we should be working together. So
Absolutely. And I think that just a really quick picture of what physio even does, I think of when someone says that I have symptoms of prolapse, I think of there's a pressure issue. And so the pelvic floor is obviously a group of muscles at the bottom of the pelvis that helps to support our organs. So I'd be thinking, are those muscles strong? Are they strong, but also are they coordinated? Like, does this person have way too much tension at the back of their pelvic floor and maybe not enough support at the front? What's the endurance of those muscles? What's going on with the whole hip and pelvis that maybe is that undercarriage isn't well supported? Or also too, I find even sometimes more the case is what's happening above that's creating too much pressure. And sometimes it's how people exercise or how they push out their bowel movements or how they hold their breath when they do their very physically demanding job. A lot of times it's during gardening. I find gardening season that women start to have issues, and I watch them pick up heavy things and how they deal with pressure in their body. And so I think, optimizing that as physios is definitely kind of our bread and butter. And then sometimes that's enough. And people will say, my symptoms are better. But sometimes it's, I'm feeling better, but there's still something. And I think of a pessary. I describe it sometimes to people as a knee brace, is that sometimes you need some support because you might do the exercises and you might have a strong knee, but when you go to play tennis, you might feel you need a little bit more support, or maybe you need more support just at rest. You have discomfort. And so I obviously, as a physio, can't, I don't fit pessaries myself. This is something that I refer often to, to you guys and say, ask them if they think that you'd be a candidate for a pessary. And I would say there's definitely a negative stigma around pessaries. Most people's first reaction is, I don't want that. Can you talk a little bit about, can you actually explain what is a pessary?
Yeah. I mean, first of all, before I dive into pessary care and all that stuff, I do spend a lot of time about education with any new patient that I meet, because for the most part, as you said, they're either not optimized or they haven't spent a lot of time doing, assessment of their pelvic floor or like what triggered all of this. And so when I do talk about it, like prolapse or incontinence, I do talk about like the pathophysiology of it and lots of things that they have as characteristics that prompted the prolapse to happen that are, either innate in their either genetics or, lifestyle or what happened, things that can't change, right? So, obstetrical trauma, menopause, a lot of those things trigger prolapse. And those are the main things that kind of worsen. And then if you already have a genetic predisposition, meaning that your family history is prone to prolapse, your tissues are just, lax and not strong, then obviously a lot of them, manifest earlier than later in life. So I do spend a lot of time on that. And once they've been optimized, so, I don't even go into pessary right off the get-go if they've not optimized anything, meaning that they're not educated, they haven't done physiotherapy, and I go send them away to one of our physiotherapists to be able to maximize that. And then they come back in 3 months like, oh, their symptoms are better, or thank you very much. No one talked about these issues with me and I don't need your help anymore, right? So once they've done that first homework or that first leg, and it's the challenge with prolapse is a long game, right? So it's not a flip switch that says, oh, it's better magically. A lot of women have these issues long-term that's not going to go away with just one intervention, or, there are a big proportion that do, because those are the ones that, either are not well-versed with what prolapse is and what the pathophysiology is, and they haven't tried anything, but there are, a bigger proportion that, need further treatment. So the next step is obviously pessaries, and pessaries, I call them like purses for the vagina, probably terrible. Yeah, it's basically an equipment that we use tailor-fitted for that person, tailor-fitted for that specific prolapse or incontinence issue. So no one pessary is the same, no one vagina is the same, no one prolapse is the same, right? So they're made of either silicone or latex, but for the most part, silicone is the main component that most pessaries are made of. They're inert, they're flexible, some are semi-rigid, and there's two families of pessaries that are typically used. One are the ones that are easily removable or supportive. They're all supportive. And there are ones that are rigid and space filling. And so they come in different sizes. The most common ones are ring with support. And I usually use it and fit it to a person that's maximized their conservative pelvic physio, if they're postmenopausal estrogen use, and they're still symptomatic, regardless of the approach that they've tried. And we do a number of sessions of visits to be able to find the right pessary for them, to see if they would improve their quality of life in terms of symptoms, right? So they can either bike ride again without having their prolapse bother them, or be able to empty their bladder a little bit more effectively. Again, pessaries are not the cure-all. They do have failure rates, and we might have a specific proportion of women that are fitted and they can't find the perfect one. But it's one of those things that as a gateway to either surgery or as an adjunct to conservative management, they can be very helpful, and they can improve your day-to-day functioning if used well and if it fitted well.
So ideally, when it's inserted, they should not feel it, correct?
That's right. Yeah.
And also too, because I think a lot of times people ask, they picture that they can't pee or poop or have sex with them in, and some of them, like all of them, you should be able to pee and have a bowel movement with them in, correct?
Absolutely.
Yeah. And that some of them, like the space occupying ones, are there certain ones that people can have intercourse with and some of them they cannot?
There are. So the more common ones that are either removable or you can have intercourse are the ring pessaries. So the ring pessaries, they're circular. They have a little hole in the middle, kind of like a donut, and they're very flexible. And so for women that are sexually active, they can have the opportunity or like the chance to remove it themselves. And I teach them how to do that, or we practice once we find the right fit, so that they can remove it and insert it on their own. And so for these women that are quite active, that are still sexually active, for most of them, they're pretty independent, right? So they're mountain biking, riding, and so they have the flexibility. They have it's more of the motivation. So if you're motivated to do it, I can teach you how to do it. It's kind of like putting earrings or getting dressed in the morning. It's the same. Putting in a tampon, putting in medications. Similarly, if you're motivated to care for it, then you have great success at being independent on a pessary care perspective. And
I often describe the visual, because I think sometimes people have a really hard time picturing their internal anatomy. And so the visual, I'm curious to know if you have a good one. I tell people to picture their vagina almost like a toilet paper roll, that, after we have children or often when we go through a hormonal shift during menopause, it can get squishier. And so the neighboring organs can start to kind of squish into that toilet paper roll, and that the pessary helps to kind of create the scaffolding or the support to the walls. Is that, would you do, and that the pelvic floor is kind of the ledge that will help support it?
I mean, that's a good analogy. I also, sometimes I've used it's a little bit crude, but, a woman's body that goes through childbirth and, postpartum stage. When you're breastfeeding, your breasts become engorged and enlarged. And similarly, it's the same with any vagina or any pelvic organ. When you're going through a hormonal shift, it becomes plump, very vascularized. The moment you go through postpartum and you stop breastfeeding, your breasts sag. It's just natural way to do that. Like they've gone through inflation and deflation, right? So the physiology changes. It's the same, like you wear different bras, right? Every year to be able to support. It's the same in the vagina, to be able to hold things up. Some people prefer a lot more rigid support in their brassiere. Some don't. Some want the flexibility of being able to move a lot more, or if they're going to have another kid, be able to breastfeed more. It's the same with any pessary. Some prefer rigidity, some prefer flexibility. And it's all to do with kind of like how and everyone's different in terms of what their physical activity is and what they want the pessary and how they want it to work for them. I have 80-year-old frail ladies that, are not sexually active, but are still mobile, and want to be able to, garden without having their prolapse bother them or rub with, friction and bleed. So we pick a very rigid pessary that only I can manage for them, meaning that they come and see me after they've been fitted every 3 months or every month. I have really great relationships with some of my elderly frail ladies that, teach me a lot, but at the same time also need a lot of ongoing care because, rigid pessaries can be a bit, challenging for the vagina to remove and can be abrasive. So they need a little bit more ongoing care. And then I have, 30-year-old ladies that are not done childbearing and would want the support when they're, caring for their 2-year-old, for example, jumping up and down, but they're still sexually active and want to manage it. So I see them every 6 months or 12 months to be able to make sure that, it still fits them well, kind of like any, anatomy, things shift and change. It could also change for, either too restrictive or too loose, right? So pessary is one of those things that are transitional, but they can provide, long-term care if somebody finds support in the longevity of it.
So do you see, so obviously I want to talk about this a little bit later, but obviously one of the barriers to getting a pessary is the wait time to actually see someone like yourself, to actually assess you, look at kind of what the tissues look like, everything, and then be able to recommend one. Because I picture, what if in an ideal world someone could get a pessary the week after they after they were assessed, or if they were able to see you right away, can you see them playing a bigger role in postpartum recovery, like in that, like shortly after someone has a birth, in that transition period?
There are some women that find them supportive, postpartum wise, you're breastfeeding, you're atrophic because your estrogen is really low when you're making a lot of milk. And so part of it too is that, I usually don't, for the first 6 weeks of recovery, obviously things are still kind of coming back to their, steady state. And so after that, between the 6 week to 6 month time period, some women need a lot of either estrogen replacement or just, recovery. It's that time period that you're not also interested in intercourse. Women are, very much so sleep deprived. And so after the 6 month time period, if they're still bothered by prolapse, they do send them to me and or to any gynecologist. And if we can see them in a timely manner after, they've maximized physio, because for the most part, a lot of either midwives or, obstetrical family physicians that manage, they do refer to physio as one of the, first steps. And if they're still bothered and challenged and they feel that, either obstetrically they got a very bad tear or trauma, I do see them, and very minimally do I find that pessary fits into that management, just because things still shift and it's still very much so in a transitional period. And for the most part, young women tend to heal really well because of the vascularization down below, and a lot of them are just not motivated to strengthen their pelvic floor because life.
Well, so then on that note, do you see that it would be like, if we kind of same as if after you had like maybe some sort of orthopedic injury, that if you kind of took a proactive approach to kind of strengthen the area and kind of maximize good habits, that maybe you'd have less likely to have problems in the future? Do you know what I mean? Maybe someone, if we were kind of a bit more proactive in our approach to postpartum recovery, that maybe we could prevent some of these prolapse issues in the long run?
Potentially. I mean, it's really hard to say because, women in the postpartum, you don't know whether it's the trauma or just their general tissue anatomy that predisposes them to kind of long-term prolapse. I mean, there's no harm. I also don't foresee myself seeing a big population of women who have 3 kids go on, follow up with ongoing pessary care, right? And so is just not one of the motivations that drives working moms or moms in general that are quite busy. But it's not harmful to seek pessary care if that's something that, would potentially improve your quality of life. I foresee it as a possible avenue of another intervention that's low risk, conservative, and doesn't jump straight away to surgical intervention that, obviously has a lot of irreversibility and complications and potentially might not be effective for women.
Totally. I think of, because that's definitely something that I've started to initiate with like the postpartum population. Women are reaching out more in pregnancy, kind of how can I best my chances of recovery. And so I've started these online groups where I work with people as soon as small groups of people, and we go through postpartum recovery together, just as you would after a knee surgery or a hip surgery, and going through things like how to optimize, strength of your pelvic floor, decrease pressure, with the goal to help you not have a lot of these symptoms, as you go through more transitions, like in menopause. And so I definitely look at it as what can we do kind of in those transition phases to support people. So then do you find then, so this was a question I had, I actually, I'm happy to share kind of some of my own personal things that I saw you having questions about a pessary for myself, because I myself have had, 2 vaginal births. I would consider them fairly traumatic in, how they all played out. And I definitely have some, not as many symptoms of prolapse. And this is where I was confused, is I don't have that many symptoms of prolapse, but I definitely know it's there. And I was coming to you very much thinking proactively and wondering, as I'm now in my early 40s and I'm going to start to see that menopause transition myself, how much does a pessary play a role in kind of preventing further issues? That was something I wanted to ask you about. And that was my thought is, that, and also how often, or do you always, when people are starting to show signs of low estrogen, does everyone that's using a pessary need to use estrogen?
I certainly do, Rick. So I think first part of your question.
Yes, 2 questions there.
Help you being proactive in terms of preventing prolapse in the future. I think it's not a straightforward answer in a sense that because prolapse is multifactorial in terms of how it develops and how it worsens, kind of like anything, a pessary is probably not a one size fit all treatment course, but certainly in terms of a population of women that are motivated, are proactive, it's not a bad thing, because for the most part, if you're, unlike yourself, not everyone's a pelvic physio, right? So, and if you can have access to a gynecologist who's going to be able to, fit you with a proper pessary and follow you along, sometimes it could help direct you about the muscles that can strengthen, just because it's fitted in an area that's potentially symptomatic. And then you can target that area by doing more, pelvic floor exercises or relaxation techniques, or being able to kind of be more cognizant of what's coming down in that sense. But obviously that's not a possibility for everybody who has prolapse, right? And so for the most part, when you see when I see someone with prolapse, they're usually quite symptomatic. They're not proactive. It's because a transition happened, like menopause or childbirth, that severely affected their pelvic floor, and they're looking for ways to manage it. And so I don't foresee it as a harm. And certainly I think there's probably studies out there that would focus on, being proactive and seeing, the transition of pessaries and seeing if that's helpful for a population of women. But I again, very challenging just because there's not enough evidence on it. And then do I give women vaginal estrogen for pessary use? And the answer to that is a resounding yes. I think everybody should be on vaginal estrogen, especially the postmenopausal population. And there's different types of formulations of estrogen that have been, marketed out there. Premarin is one of them. And so some people are, not keen on that just because of how it's made. But There's also synthetic ones that are out, available. And, obviously, if you have good coverage, you can make yourself available to any type of formulation of estrogen. But how they work is that, especially in the postmenopausal population where they're no longer having their ovaries supplement to be able to have that connectivity and tissue strength and elasticity. The vaginal estrogen use helps give them back that elasticity, or like vaginal estrogen. So it reduces the risk of bladder infections, and it's very negligible in terms of how systemically absorbed these estrogens are. So I usually say, like, most of the fear around use of it is the risk of malignancy, or the worry of cancer. And for vaginal estrogens, there's not been any evidence to support that it increases your cancer risk. And it's my spiel all the time, saying, like, vaginal estrogen, the only risk to it is that you have to remember to put it in. And for it to be effective, you have to use it, right? So especially for pessary care, we're removing a very either rigid or flexible, equipment. It has to be able to, your vagina has to be able to stretch and, accommodate it. And there's nothing worse than pessary use in a vagina that's not estrogenized, because it can be very fragile and atrophic and bleed easily. And so that's why the ongoing pessary care requires us to be able to kind of look for abrasions, look for injury, because although you don't feel it, the properly fitted pessaries are supportive, they're not painful, but they can also cause friction. And if you're not using estrogen, it can increase your risk of having these abrasions happen. And
I think that's great, because I'm seeing more and more women. I think because we see a lot of the same clients that are using estrogen use is definitely going up, which I think is a good thing, because the awareness is out there and just how beneficial it can be. Really quickly, if I was just to help, because I think sometimes people have questions around, like, okay, what does this look like in my day? And if I could talk about, I think maybe I would find myself on one end of the spectrum. And you mentioned some people that need a little bit more support. But when I went in to have a fitting with you, I thought it was really interesting, because obviously you did an assessment or whatever, but then, kind of you taught me how to insert it myself. And then I was interested in using it for activity. So I imagine there's some people that just use it. Maybe they're going to be on their feet all day, or maybe they use it with certain activities and then take it out, maybe after the activity or at the end of the day. So, you can take it in and out if you're able to with your fingers. And then you would just take it out and clean it with just soap and water. Correct.
Right.
Store it in like a dry place. And then some people like you mentioned, you would be inserting it when they come to see you in the clinic, and they'd come back to see you after a certain amount of time. You would take it out, clean it, and reinsert.
That's right. Yeah. So the population of women that use pessary is very diverse. And so there are ones that are quite independent. And then I have ladies that are, frail, either, wheelchair bound, for example, or very minimally mobile with a walker, for example. And so these ladies that require pessary care obviously are not dexterous enough or flexible enough to be able to bend and reposition themselves, and to be able to remove it without injury to themselves, for example. And so I do see them in intervals. So there are ones that I see as often as every month, because their prolapse is quite significant. They're not surgical candidates, or, they just, prefer the conservative way to manage their prolapse. And so either I see them every month or every 3 months, or some every 6 months, for example. I remove the pessary, make sure that there's no abrasions. And part of the follow-up too is, ongoing education. There are emergencies with prolapse, and so either you can't pee, for example, or it's irreducible, you can't put it back in, and that's why the lengthy wait as well, right? So most prolapse impact quality of life, and it's not harmful. It's not going to kill people. So if, for the most part, the wait time is to make sure that either the family doctor has educated themselves, or even, they've sought physiotherapy. And that's part of my triage as well. If this patient that has prolapse complaints has not seen physio or has not optimized their care in other ways, please do so before, they come and see a gynecologist, because for the most part, I spend about my first consult as education, and it's challenging if they haven't. And part of it too is not so much the onus on other healthcare providers, right? It is just the nature of our healthcare system that education is not a big portion of it at this point. And prolapse is one of those things that are, a very much so a black box, because the population of women that are quite symptomatic are not the ones that are going to go on the internet and Google what prolapse is, or, find solutions to it. So,
exactly.
Yeah.
So, and then obviously with the ongoing support, like you said, you're taking it out, you're examining their tissues and maybe adjusting the pessary size if needed. But if they're managing it well, there's no reason it would need to be discontinued.
That's right. Yeah.
Okay.
And so I typically, there's only two, I shouldn't say two, but there are a number of ways that women discontinue pessary. Either, they've tried it for a number of months or years, they found it effective, but it's not enough. For example, these are the ladies that are young. When I say young, they're still postmenopausal, but they're still physically active. Like, for example, one is a tennis player and messes up their tennis game to be able to kind of shift their pessary in the right position because they're physically active. So then that's when you start, as a transition to discussing surgery, as a possibility for them, or the ones that, their prolapse has gotten worse and the pessary doesn't fit anymore, and they're still overflowing or quite symptomatic, and we've shifted them to the biggest and most space-filling one. So I either shift their pessary care to monthly to be able to kind of adjust it for them as needed, or they just say, like, either we also discuss surgery for women that are candidates for it, for example. And it's an ongoing discussion. So it's just, there's no one, route that most women take. But, there are some steps that I follow, or most of us follow in terms of care.
I love how you point that out, because I do think, again, another misconception's always been that I need surgery for this. If anything's not right, I need surgery. And I think what you've talked through is that there are so many conservative steps that can be taken first. I want to educate them about that area of their body. I'd love them to go maximize what they can with the physio. I'm going to see if this person would benefit from some hormone therapy to maximize tissue quality. And then if they need a pessary, we're going to try that. But if I exhaust my conservative options and, someone's pessary is not fitting, maybe it's falling out, it's uncomfortable, I can't evacuate properly, my quality of life is affected by my symptoms, and I haven't been able to find anything that improves that, then that's when maybe surgery would be considered.
Mm-hmm.
Yeah, but not first.
And I'm not opposed to kind of discussing surgery too on the first couple of fittings. And part of it too is this education, right? So some women are not motivated until they find out what's the end of the line, and basically find out, what the next steps are. So, so to speak, right? So I say, like, pessary is great, but, this is what happens if you don't maximize your care for physio or ongoing pessary use. This is what surgery looks like. It's lengthy recovery. You have to give up, your physical activity for 8 weeks, for the healing process. There's, depending on how bad your prolapse is, this 30% failure rate, and you want to make sure that people are aware that it's not all, positive in terms of surgery. It's not going to be a flip of the switch that makes everything better. There are complications that, although we try our best, obviously, not to encounter them, it is a possibility. And for women that are motivated, that, this is the only way that I can, foresee myself improving my day-to-day activities and are willing to go through that, recovery and complication and risk that potentially can happen. I'm a proactive person in terms of education, because, everybody nowadays is talking about being able to make that decision for yourself, and being able to educate yourself as to what your options are, and and if surgery is the route that somebody chooses to go through, I also want to make sure that I can increase their chances of success. And the only way to go about it is to make sure that they're aware, of both sides.
I look forward to, I'm going to follow this discussion up eventually with someone that, someone hopefully in your team that would talk to me about surgical options, because I want to kind of talk through all the options for people. Mm-hmm. Now, really quickly to tie it up, a couple barriers that I kind of pull out of our discussion is, one, that the first line defense or the first line treatment is you have to pay for it in our system. Physio, unfortunately, that's not covered by our system. So that stands out right away, is that the first line, unfortunately, I mean, everybody has, well, not everybody, sorry. A lot of people have benefits that will cover it. But I think just pointing out too, that that's what it is right now, but that there are lots of benefits. And I think that just as long as, like you said, people are educated, they can make the decision themselves, what they spend their resources on, right?
Absolutely.
That's
and
one.
I think, like anything that has great benefits, there's, for this small amount, I would say small, it's probably someone who's under a lot of financial tension might not find it small, but the benefits of one intervention, I don't find that the monetary value is a big barrier, right? And so, if it's, I'm not sure how much a consultation, $70, $140, $300
to meet us for 45 minutes the first time is around $130.
Yeah, I mean, similarly, we bill MSP the same for consultation for a gynecology. And I think, that amount I always tell them, even if you don't have extended healthcare benefits, just to meet with a physiotherapist to educate yourself with how your pelvic floor works and give you that first steps to be able to engage your pelvic floor. You can come away for 45 minutes knowing your anatomy better, which you can't do online. It's one of those things that are hands-on. And the trouble with the pandemic and seeing someone virtually is that you can't have that, right? Like that hands-on education. I can't see what your issue is with prolapse virtually. So it has to be, I could talk to you about symptoms, and 90% of diagnosis is all history. But at the same time, there are some conditions that require us to be face-to-face. And it's the same with physiotherapy, I feel, and like you said, to tie it all in, we spend so much time with our upper extremities and lower extremities and strengthening them, but pelvic floor carries everything. So yeah. I think that.
Well, and I think too that people picture that I'm going to have to go see the physio every week for the rest of my life. I like you said, one visit can be, sometimes people like, that's all I needed. If I see someone 5 times, that's a lot. So just to give people an idea, the other barrier I hear is your wait times. And I'm just wondering if you can quickly touch on, there are other communities that have nurse run clinics or that help to alleviate your system a little bit or your schedule. And I'm wondering if you can speak to, I know there's like a big answer to this question, I'm assuming, but can you just really quickly touch on why do we not have one of these pessary fitting clinics in Kelowna?
I think, obviously I've only joined the community in the last 2 years, so I can't speak to what it looked like prior to that, but I think part of it too is resource. Bigger communities like Vancouver, the Lower Mainland have bigger communities and resources to be able to have a nurse run clinic to manage pessaries. Unfortunately, we don't have that here, and mostly likely to do with funding. It's not for the lack of motivation, and certainly not to do with the population that needs it, and being able to set that up. And so I think You know, a lot of us would love to have a nurse to be able to, or even just a clinic for education as a first step to be able to kind of, you know, manage a lot of the ongoing care, because certainly there's a need for it. But it has a lot to do with funding, you know, the short answer of that, right? So, yeah.
A really quick call then. I have done a couple episodes with Dr. Locke, a urologist in town, who is always doing research to help collect data to help argue that we could use one of these in town. And so I'm going to make sure that I put in the show notes how to contact the urology team to see if you would be a potential candidate or a subject for their research. And most of they just involve a questionnaire, but the more people that participate in this, the more data that we collect, the more argument there is to be able to have one of these women's health-based clinics in Kelowna. So I'm going to link that in the show notes, and I would encourage anybody listening to take a listen or take a look at that and then see if it applies to you. Is there anything else? I thank you so much for your time. I know you're not only a busy mom, but a busy clinician. And I wonder if you have anything else that I didn't ask you about or that you want to make sure that you say before we close.
I think part of it too is that we want to make sure that women have lots of access to education. And I think that's, you know, currently what we're working on as a community, to be able to have that, you know, resource in one setting. And so it's still ongoing. And, you know, I want to encourage women to find reputable sources of, you know, for education with how their, you know, quality of life, or prolapse, for example, is one topic, because there's lots of misinformation out there, and it's really challenging to negate all of that. And you obviously spend a lot of time, you know, as healthcare professionals, I'm sure in your practice and in my practice, of what those misconceptions are, it's available out there. And so, you know, obviously it's hard to be able to find resources, but, you know, going through your family doctor or your physio or your gynecologist to make sure you kind of, as a first step, before everyone has lots of questions, but don't know where to find the answers. And so, you know, as a first step, when you do meet, you know, one of your healthcare professionals, make sure you come away with asking, what can I look up at home? You know, how do I educate myself? And I do give some resources, but at the same time, obviously, everyone gets bogged down with information for the first visit. And so I would encourage people to be proactive in looking for resources and how they can manage it on their own, because part of it too is like a lifestyle, right? So you want to be able to kind of manage it independently and being able to know what resources are helpful for you.
I think that's great.
As evidence.
We definitely come from, I think, a model where, you know, you go and you expect, or you're looking for help from the healthcare provider, which you will get. But I think recognizing, like you said, educating yourself so that you can help be a part of the care as well. Because again, we have limited time as practitioners, and sometimes you need to be able to help us understand yourself too, right? As a client, because everybody's going to choose a different option. Like you laid out, there are different options and different levels of care. Everybody's going to come at that very differently.
That's right. Yeah. I always emphasize individual care, right? So not one person will come out the same. You know, recognizing the treatments that we talk about. It might be the same template, but everyone focuses on one area that's more pertinent to them. So I find that, you know, the more proactive you are, the more success you're going to get in terms of, you know, managing your concerns, gynecologically perspective anyway. So
that's awesome.
And I think, you know, this podcast are like one of those, you know, resources that's super helpful, because everyone learns differently for different people. So
totally. Thank you so much for your time. I really appreciate it.
My pleasure. Thank you so much for having me.